Thank you for joining me for this talk called The Science of Obesity. Where might this lead clinical practice? I'm Dr. Sean Wharton. I'm an adjunct professor at McMaster University and at York. I'm also the medical director of the Wharton Medical Clinic. Obesity is a pandemic. It affects 650 million people to 1 billion people across the globe and 9 million people here within Canada. Excess adiposity causes or exacerbates multiple medical conditions, including diabetes, cancer, and COVID-19. We know that the inflammation caused by the white adipose tissue causes many of these conditions. Where there is an inability to properly store excess calories within healthy subcutaneous fat depots, the energy ends up in visceral adipose tissue and becomes dysfunctional. These cells can become hypoxic and it can lead to tissue dysfunction. So how good are we at treating elevated weight? Unfortunately, we've not been very effective for a long time, and only recently are we getting a little bit better. This Canadian study from my clinic looked at 7,000 patients over 7.5 years, all doing a lifestyle management. That's healthy eating and some exercise. So we wanted to know weight loss and the patterns of weight loss. We plugged the data into a fancy program and came up with these 7 patterns. Let's focus in the center, the purple and the yellow lines. This is representing weight stability or minimal amounts of weight loss of 2.3%. And this made up 2/3 of the patients. So a small group of patients also did well. They got up to 21% weight loss. But most patients, as you see, cannot achieve significant weight loss with just lifestyle interventions. So do we need greater weight loss? The answer is yes, we do. Then let's look at the improvements we get with medical conditions with further weight loss. We get some diabetes prevention at 3% weight loss, but even more at 10%. Many conditions need up to 15% weight loss, such as diabetes remission. So more weight loss is actually better. Well, let's talk about the science of obesity and why we can't sustain weight loss without understanding the actual science. So here's the challenging part. Unfortunately, the science of obesity is currently in its infancy, and that's not good. Why? Obesity is not new, and we've known about this connection with obesity and disease for a long time. Why is it so understudied? The answer is likely due to obesity bias. People who don't think that obesity is worthy of study, it's not a disease, it's more of a social problem. Let's just get on with it, eat less, and exercise more. So we have to deal with this obesity bias first. When we get past the obesity bias, we're now faced with the fact that the obesity pathogenics is really complex. It involves biological, genetic, psychological, and also environmental factors. Body weight is meticulously regulated by the brain, an organ that we barely understand. So what causes this elevated weight in the first place? When we look at the science of energy homeostasis, we see that even a small surplus of a caloric intake, less than 1% over the energy expenditure, can result in accumulation of excess weight over a few years and lead to an elevated BMI. Much of this is driven by the genetic factors coding for eating behaviors. Unfortunately, once that weight is there, the biological defense mechanisms kick in and keep this weight elevated. So what about these genes? 25 to 50% of the risk for obesity is actually inheritable. Greater than 140 genetic regions are now known to have an influence on obesity traits. Geneticists have actually started to uncover the genome of actually thinness. So these genes code for areas within the brain. The three areas of the brain most involved are the mesolimbic, or the hedonic system, the hypothalamus, or the homeostatic center, and the frontal lobe, or the executive functioning center. These regions of the brain are primarily designed to protect against weight loss. The intensity of this protection is driven by the genetic coding. As we gain a greater understanding of the workings of the brain as it relates to elevated weight, we can develop treatments that work within these areas. So what influences the brain? Lots of things like sight, smell, emotions, and the gut. We have a gut-brain circuit. Hormones like GLP-1 and PYY delay gastric emptying and are potent anorexogens secreted by the L cells. An anorexogen decreases weight. They're secreted by the L cells within the small bowel in response to food ingestion. These are the good hormones, and people living with obesity either don't have enough of them, or they're not making the hormones not making it to the receptor within the brain. Leptin and insulin are also part of the good hormones and bind to their respective receptors in the arcuate nucleus to decrease the food intake and increase energy expenditure. Unfortunately, in people living with obesity, they either have leptin resistance and they have insulin storing energy in fat cells well before the message from insulin goes to the brain to tell the brain to stop eating. The gut microbiome is another important and emerging scientific advancements, but there are no treatments ready yet in terms of the gut microbiome. So what does this science lead us to conclude about obesity? This slide is likely the most important slide within my slide deck. The science tells us that obesity is not caused by overeating, but that overeating is caused by obesity. This is not just a play on words. It has been shown in many studies that overeating cannot cause obesity if you do not have the neurochemical and genetic profile to develop this elevated weight. On the other hand, if you have the genetic and biochemical setup for obesity, this leads to hunger, cravings, and also overeating, leading to the elevated weight. Digging deeper into the science, some time ago, my mentor, Dr. Arya Sharma, wrote a review on the etiological framework of obesity. Weight is controlled by the in and out of calories. And the in is the dietary or the food, and the out is the metabolism and also the active movement, activity. Let's explore the science of metabolic rate. All of these factors listed here can have an effect on your metabolism. Most of this we cannot control as it is defined by our genes, but let's look at some of these factors. We have a small amount of control of our muscle mass, although most of it is determined in a genetic fashion. 1 pound of muscle burns 6 calories, and 1 pound of fat burns 2 calories. Stated a bit differently, if you eat 6 calories, this can be used to maintain 3 fat cells, or it can be burned up in the repairing of a muscle cell. Resistance, activity, and ripping muscles can clearly have an impact in terms of maintaining muscle mass during weight loss. Another factor in metabolism is age. As we grow older, our mitochondria dies a bit every year, and we lose our metabolic rate, making it harder to maintain weight as we age. This mitochondria is predominant within muscle tissue. The biggest challenge to metabolism is weight loss. As you lose weight, your metabolic rate drops. 3% drop for every 10 pounds lost, and that is significant. So I like this study by Kevin Hall. Kevin Hall is a Canadian working at the NIH. He looked at metabolic rates and compared patients having massive weight loss. He compared bariatric surgery patients to the Biggest Loser competitors. The Biggest Loser is a TV program designed to have competitors lose weight with exercise and also diet. But essentially, this diet is close to a starvation diet at many times. Participants in both groups lost a significant amount of weight, on average 60 kilos, which is about 130 pounds. So who lost more muscle versus fat? Well, the bariatric surgery patients lost more muscle than the Biggest Loser group did. So the Biggest Loser competitors were exercising and doing resistance activity. So they retained muscle mass. This is good news. So then, who had the lowest resting metabolic rate at the end of the study? We would expect that the surgery patients would have a lower resting metabolic rate due to less muscle mass, right? Well, wrong. The Biggest Loser patients had the lower metabolic rate. Why? They have more muscle mass, so why a lower metabolic rate? It turns out that a starvation diet drops your resting metabolic rate in a severe manner that overcompensates for that retained muscle. Starvation likely modulates hormones such as leptin, leading to more efficiency and a lower resting metabolic rate. Here we can see that leptin dropped more in the Biggest Loser cohort than in the bariatric surgery group, maybe due to this starvation type diet, especially at the end of the competition. Here is where we get into the science of metabolic adaptation. So metabolic adaptation means that you have a lower than expected metabolic rate. An example of this is if somebody loses 100 pounds, from 300 pounds down to 200 pounds, their metabolic rate would be lower than a person at 200 pounds who had never lost weight. Even worse, if you regained weight back up to 300 pounds, their metabolic rate may never recover and stay very, very low. What we know about the Biggest Loser competitors is that almost all of the participants regained all of their weight, and some of them more than their baseline weight within a short period of time, within a year and up to the 6 year mark. Here we see Sean Wharton. Before the competition, he weighed 444 pounds. After the competition, he was 289 pounds. But over a few years, he regained all of the weight, going up even higher to 450 pounds. Unfortunately, his metabolic rate is 500 calories lower than it should be, making it very hard for him to ever lose weight again, at least to lose weight easily or properly. This table from the study looked at the competitors in terms of their expected resting metabolic rate versus their actual or measured resting metabolic rate. So at baseline, the expected metabolic rate was close to the measured one. We have an expectation of that. At the end of the competition, the measured was almost 300 calories lower than what it should be, metabolic adaptation. And then here is the kicker. 6 years later, after they regained the weight, the resting metabolic rate is lower than what it was when they were 60 kilos lighter. This is severe metabolic adaptation, and it seems like the Biggest Loser competitors suffer more metabolic adaptation than even other people who lose weight. So which hormones and metabolites are predicting this metabolic adaptation? The bottom line is it is not really clear. Here, Kevin Hall looks at a number of hormones and a number of metabolites. There are some changes in the T3, but not the other thyroid levels. So this wasn't a factor. But leptin was lower and did not recover. So this may be a factor, but we have not figured out how how to give a replacement of leptin, or why it stays low despite the recovery of fat cells. Remember, leptin comes from the fat cells. So there may also be other hormones that are contributing to this lower metabolic rate. So all of the science in metabolism is new, it's evolving, and we may see interventions in this area soon. So what do we have currently as targets for obesity management? We have the brain, the hormones and the neuropeptides. We have the gut with hormones going to the brain, the peripheral tissue, and we also have the genes in terms of the modulation. Currently, the area that has the most immediate promise and some success is the modulation of hormones and the neurochemicals within the brain and also gut. Our current understanding of the brain-gut hormones has helped us to design treatments that actually work. Psychological interventions working in the brain, pharmacotherapy and surgery working in the brain and also gut. Based on this science, there are now options for pharmacotherapy. We have some medications approved in Canada and some emerging meds also. Liraglutide was the first effective weight management medication to come to Canada in 2015. Liraglutide concentrated within the hypothalamus and the arcuate nucleus. Weight loss was quite good in the completers at 9.2%, and intention to treat last observation carried forward was a 8% weight loss. We don't use intention to treat and last observation carried forward any longer. We use estimans. And they would have come in handy here as the dropout rates were quite high, between 30 to 40%. And that's where estimans shine. So the bottom line here is that for the first time, patients got some relief from their obesity from a daily injection. The primary side effects was nausea, affecting up to 40% of patients, and this was both tolerable and also transient. We did a real-world study with liraglutide and found that we got good results with an 8 kilo decrease and a 7% decrease within weight. We also saw nausea as a side effect, but we also noted that constipation was a challenge for many patients. The second effective drug to hit Canada was the combination drug Naltrexone and also Bupropion. Both of these drugs work within the brain neurochemistry, and it's a combo drug. Likely they're working within the hypothalamus and also within the mesolimbic system. Weight loss achieved at the 1 year mark was fairly good. It gets up to 8% in the completers and 5.4% in the intention to treat. Again, here the dropouts were nearly 50%. So last observation carried forward was clearly the wrong parameters to use. Again, estimans here would have certainly helped. But overall, we're seeing about an 8% weight loss here. There was improvements in cravings, and this is a real problem for many patients. The main side effect, again, was that we saw some nausea. This medication cannot be used in patients who have a seizure history or those who are on opioids. So far, the two medications that we have in Canada have not pushed past the 10% weight loss mark. Enter semaglutide, a once-weekly GLP-1 analog. This trial published 3 weeks ago in the New England Journal of Medicine in patients with overweight and obesity without diabetes, using a higher dose of semaglutide compared to the approved diabetes dose of 1.0 milligrams. Here we finally cracked the 10% average weight loss range, getting up to 15% weight loss with semaglutide 2.4. Estimans are actually used here, and that good news. But even more good news is that there was a limited number of dropouts and a limited number of loss to follow-ups within this clinical trial. And this is the real impressive aspect, and the reason why many people are calling this study a game changer. 1/3 of patients got close to the surgical weight loss of greater than 20%. We've never seen that in a non-surgical trial, especially in a medication that you can take once every week. The main side effect here was, again, nausea, dissipating over time. Another emerging medication is amylin, again targeting the brain, decreasing appetite and increasing the feeling of fullness. The monotherapy trial here shows a 10.8% weight loss, but the compelling studies are looking at amylin combined with a GLP-1. This phase 1 trial showed a promising 17% weight loss. Early days, but very promising. Nausea and GI upset were again the main side effects. The newest emerging medication is the molecule tirzepatide, a dual agonist of GIP and GLP-1, treating both diabetes and also weight. Most of the clinical trials with tirzepatide are in patients that struggle with diabetes. The studies are represented here in blue. But the weight management trials in patients with and without diabetes, seen here in purple, are also pending. So what can we expect from tirzepatide? In patients with diabetes, this phase 2 trial showed 11% weight loss. We know that patients with diabetes lose less weight than those without diabetes, likely due to metabolic adaptation, a phenomenon we have yet to understand, as I previously talked about. Therefore, we can expect even greater weight loss with this molecule in patients without diabetes. The main side effect of tirzepatide was, again, nausea and GI side effects. So, in conclusion, obesity is prevalent, the inflammation causes multiple complications, and it is understudied, likely due to obesity bias. The science of obesity is a complex science, and it's driven primarily by brain neurochemistry. Diet and exercise alone are not sufficient for obesity management. Effective treatments for obesity are limited, but are increasing rapidly. And the gut hormones and peptides are the primary pharmacotherapy agents and primary targets we're using to help to decrease weight. Thank you very much for your time.